Hello and welcome to Veterinary Instrumentation's latest episode of Under the Skin, a videography series introducing key procedures, products and devices from the VI range. In this episode, we explore the correction of hip luxation in dogs and cats using hip toggling implants available from VI. So, let's go under the skin. Hip luxation, also known as coxofemoral luxation or hip dislocation, is a common orthopedic condition in small animals, particularly in dogs and cats following trauma. It is characterized by the displacement of the femoral head from the acetabulum. Understanding its pathogenesis, proper diagnostic approaches, and available treatment modalities is essential for effective management and optimal recovery. The hip joint is a ball and socket synovial joint formed by the articulation of the femoral head with the acetabulum. Its stability is maintained through several anatomical structures, notably the primary joint stabilizers of the joint capsule and the round ligament of the femoral head, the ligamentum teres. Disruption of secondary muscular stabilizing components, typically due to trauma such as vehicular accidents or falls from height, can lead to luxation. Pre-existing disease such as hip dysplasia may predispose animals to luxation with less forceful trauma. It is important to recognize animals who develop craniodorsal hip luxation with minimal trauma, as this will influence which treatment options are likely to be successful. Animals with hip luxation typically present with acute, non-weight-bearing lameness in the affected limb. For a craniodorsal luxation, the affected limb typically appears shorter and is carried in an externally rotated and adducted position. In caudoventral luxations, the reverse is generally apparent. The limb is longer, abducted and internally rotated as the femoral head is lodged within the obturator foramen of the pelvis. On examination, there is typically reduced range of motion associated with pain, and the greater trochanter appears displaced from its normal position. Confirmatory diagnosis is achieved through radiographic imaging. Standard ventrodorsal and lateral views of the pelvis are sufficient to visualize displacement of the femoral head and assess for concomitant fractures. Advanced imaging, such as CT or MRI, may be employed, but this is not usually necessary. It is important to differentiate hip luxation from femoral or acetabular fractures, as treatment and prognosis differ significantly. Treatment options for a hip luxation fall into two broad categories, namely whether the treatment is hip-preserving or whether salvage intervention is required. Preservation options are appropriate when there is a history of significant trauma, no radiographic evidence of hip dysplasia, no evidence of femoral head fracture, or no evidence of acetabular fracture, specifically of the dorsal acetabular rim. There are several treatment options for hip preservation. Here we examine the hip toggle procedure utilizing implants available from VI. The patient is positioned in lateral recumbency with the affected hip uppermost. A craniolateral incision is made and the gluteal musculature is retracted. The joint capsule may be torn from the previous trauma and not require incising. The femur and femoral head are retracted craniodorsally with a small Hohmann retractor or Langenbeck. The tip is placed in the caudodorsal acetabular rim, taking care not to damage the joint capsule, labrum, or articular cartilage of the acetabulum or the femoral head. The hole in the acetabular fossa should be made dorsal of center, just ventral to the articular cartilage. Using a drill sleeve, a hole can be made. It is critical that the drill bit is well controlled, as dropping through the medial acetabular wall may damage the intrapelvic structures, including the rectum and urethra. The femoral tunnel is drilled between the insertion of the teres ligament at the fovea capitis and the lateral femur, slightly distal to the third trochanter in the middle of the femoral head and neck. Drill bit size is established based on the size of the implant and the manufacturer's guidelines, but ideally should be less than 20% of femoral neck width on ventrodorsal extended hip radiographs. There are 2 approaches and multiple techniques to drill the femoral tunnel. The tunnel can be drilled outside in from the lateral femur to the fovea, or inside out from the fovea to the lateral femur. The tunnel can be made either using a drill bit, using a freehand technique, or an aiming device. Or it can be made using a Kirschner wire placed either freehand or guided and over-drilling with a cannulated drill bit. Whichever technique is used, it is critical to ensure the tunnel exit and entry is at the fovea capitis, whilst direction of the tunnel is likely less critical if the tunnel stays within the femoral neck and exits within the femur proper. The toggle is placed into the acetabulum using either an introducer or a pair of artery forceps. Pulling on the sutures will help seat the toggle correctly. It is often possible to visualize the toggle through the drill hole, ensuring it has flipped into the correct position. A loop of orthopedic wire folded in half can now be passed through the femoral bone tunnel in the direction of the femoral head. The wire can then be threaded through the liga fibre suture and pulled back through the bone tunnel. Pulling on the suture will now lead to reduction of the hip joint. The sutures can then be tied over a titanium button. It can be helpful to tie one surgeon's throw, move the hip through the range of motion before final tightening and tying. This is followed by the joint capsule being closed and a routine surgical closure. For further information on the VI range of instruments and implants for hip toggling surgery, please visit our website or contact our specialist technical support team. Join our online community by following our social media pages to keep up to date with the latest releases of training and education material, as well as company updates.